This podcast is hosted by the Institute for Addressing Strangulation. Part 2, Strangulation and Domestic Abuse.
To me, like I look at strangulation as this mechanism of coercive control, where it is a tactic that perpetrators are using to either gain control or maintain or sustain control in a relationship. And so they do this through sometimes the violent tactics, but a lot of times it's a lot more the psychological manipulation and things like that. And so over in like the UK and England and Wales and things like that, you actually have coercive control laws and are actually collecting evidence on that in your annual victimization survey. And so I've been reading some of the articles about how they have adapted those questions, and I collected a sample using what the measures that they're using for your crime survey for England and Wales. And I collected data here in the United States, but particularly with queer populations, because I wanted to see, well, what does strangulation and coercive control look like when it is two men or two women, and exploring the idea that sexual orientation might be another kind of insecurity and or trigger that fuels maybe a lot of this violence. And so I analyzed this data, and the measure that I had for we were limited in terms of the number of questions that we have. So the measure for strangulation is like, has a person ever strangled, choked, and or put pressure on you in ways that made it feel like you were unable to breathe. And so we have the act, and then we also have the consequence of meeting that, like, and to the point that you were unable to breathe. And so what was really interesting is I want to look at like prevalence estimates, but specifically looking at like is the risk of strangulation related to how someone identifies. So is someone that, because what we see in now these national estimates is, so much of what we focus on strangulation is it generally is a gendered crime, primarily being perpetrated by men against female intimate partners. But when we actually look at the studies of looking at prevalence estimates of who's ever experienced asphyxiation, we really don't have, like, we have some national surveys and one item, but we don't know anything beyond that. And all the other information that we get, like, I've combed through all these studies, and so much of the research on strangulation has really come from official data, so police reports and medical records. So there really hasn't been a survey of the community about their experiences of strangulation beyond the research that's coming out now about the connection of strangulation and sex and things like that. And so I wanted to look at, what is the prevalence in queer communities and who's at the highest risk, and more specifically this concept of like bi-negativity. And so in the national estimates, it's now showing that like women who identify as bisexual tend to experience the most severe forms of intimate partner violence. And granted, in our NISFAS, the National Intimate Partner and Sexual Violence Survey, the majority of, like, it was like 75% of bisexual women said that the violence was perpetrated by a man. And so in this survey that I did, I paid like a market research survey to get me a large sample of predominantly queer. So it's about 70% of people who identify as LGBTQ. And it's people who have had, relationship experience. And I am looking at lifetime estimates of asphyxiation assaults. And so what I found really interesting is that it's not necessarily how people identify, it's who they've had relationships with in the past. And so so one of the things that what I'm looking at is like, so when you have kind of two men or two women, you can have different a lot of the power dynamics in heterosexual cases can be the same, but there are unique aspects of it. And so one of the things that I'm looking at is like degrees of outness. So if you have like identifying as part of the community can be outness, because not everyone who's in a same-sex relationships identifies as gay or bisexual or lesbian. And is that like a sore subject for the couple? And is that something like, is the strangulation the result of the perpetrator feeling insecure about their own sexuality? Or are they jealous that this other person can be out and they can't, or vice versa, where they can be out but their partner can't, and that is frustrating. So is it like that, or is it more that having a partner who has had relationships with both men and women versus how they identify? And so that's what we're finding is that really it seems like what we found was women who have only had relationships with women were actually like 3 or 4 times more likely to experience strangulation throughout the life course, compared to any other couple configuration. And that is really surprising to me because that kind of goes against everything that we have encountered. And I've talked to a lot of my strangulation expert friends and stuff like that, and some are saying, like, anecdotally, we've had some cases where women have been strangled by women, but the majority of the cases that they encounter generally are women that are strangled by men. But most of my strangulation expert friends are people that work in the field, so they're cops or prosecutors. So they're seeing these, and we know that queer populations are less likely to involve the police.
Yeah.
And that generally women, predominantly white women, are most likely to contact the police in domestic violence cases. So I thought that was really interesting. And so I'd love to kind of continue kind of looking into that and, helping people understand that, like, yes, it is, can be a gendered crime, but that it is also happening in same-sex relationships as well. And I want to do more research to figure out, like, well, how do we identify a dominant aggressor in same-sex cases to better understand, what's going on. And so I'd love to collect some more data to kind of confirm this and corroborate this. So I'm in the process of writing this up. And so, but then also, like, what are the implications of this? Because I'm thinking, like, how do we give first responders the language so that they can use to ask the right questions and get the information that they want? And I've talked to, representatives from like trans organizations and stuff, and they're like, I think this is a really interesting area. You have to realize that, some of the things and the language, might not be questions that officers would feel comfortable asking people. Like, especially if you're on scene, you don't necessarily want to ask people about their sexuality unless you think it's like relevant and stuff like that. So in terms of putting like a sexual orientation or some type of measure on like a risk assessment, like, have you ever had, same-sex relationships? Like, it'd be interesting to see, because I could see that also create issues with victim cooperation and different things like that, or it pissing off the person that they are talking to, or different things like that. But that's just kind of something that I thought was really interesting in the research that I'm working on now. And so I'm curious if you've seen anything like that in terms of female asphyxiation.
No, and so that's incredibly interesting. And I'm just thinking back to, so the police data that we have so far has been aggregated. So we have a percentage of victims who are X gender, X sex, a percentage of perpetrators, but we don't have that kind of matched in terms of this perpetrator was with this victim. Where we do have that has been through our analysis of domestic homicide review. So we've analysed cases where we can see in each case the sex, gender, age, ethnicity, and relationship and contextual information of each victim perpetrator in those cases, where they have been reported. And in some cases these data points aren't recorded, and so we've got that recorded. We don't know what's going on. But I'm just thinking back to our fatal strangulation domestic homicide review analysis. I think we had 3 female perpetrators out of the 75, I believe, cases that we analysed. So 3 of those perpetrators were female, and 2 of those were sort of co-conspirators with a male perpetrator as well. So there was a female and a male who were both convicted of strangulation. So it wasn't necessarily clear who did that act, but because of the act, you would assume it was one person rather than both being able to do it at the same time.
Right.
And then in the one case, so in one case out of 75, it was a female perpetrator and a female victim. So actually, yes, we have seen female. We haven't seen any significant proportion of female to male strangulation, and I wouldn't say even that was a significant proportion of female strangulation. So I think it's really important, and I think it also speaks, I think, to your paper on victimization and risks. And I think your point around like prior relationship also came up in that paper. And disability, I think, was also a key risk factor.
Yes.
There are so many elements of people's identity that, if not captured, how can we start to tie this all together and better understand it? Can you speak to that a little bit more?
Yes. And so, and that's what I mean, disability seems to be a very common predictor of victimization, regardless of the type of crime, whether that's identity theft to intimate partner violence. And so, and I think that speaks largely to, like, I really like this theory of target congruence theory, which kind of, so a lot of the research is around like routine activity theory, and that's basically argues like how victims come into contact with the offenders, and why crime happens when there is no one around to watch. But that's primarily designed for like street-based crime. It doesn't always align with intimate partner violence because sometimes victims don't have autonomy over their routines and thus. And so the target congruence theory kind of builds on that, and it really focuses on like what are the characteristics of victims that perpetrators perceive that they can exploit and or take advantage of. And so disability, I feel like, is one of those things is sometimes, there are like you can have the spectrum of it where you can have the visible disability where you see an elderly woman walking across the street or in a wheelchair, and someone views them as a vulnerable target to pickpocket or attack kind of thing. And then you have on the other side of the spectrum the more invisible disabilities in terms of cognitive learning and things like that. And so and in the prior relationship, like I personally think like gold to a batterer that's looking for a new partner is, a survivor that brings up how they had an abusive history or something in their childhood. I feel like that sends a message to perpetrators. I don't want to give perpetrators a lot of credit in terms of like they're being very calculated about this, but I feel like they pick up on things like that allows them to be drawn to people that they can have the power and control over. And so when there are these type of disabilities, a learning disability or a cognitive disability and things like that, that plays into like the victim's mindset in terms of like their ability to kind of comprehend what happened, but also like understanding how our system operates. As someone that is educated and gone through school and studies the justice system, like there's still so many things about the system in every different community that is different that would be like confusing and hard to for me to go through. So someone that has like a disability, learning disability, like these are just tactics that abusers will manipulate. Same thing with like substance abuse. Like that's another thing too, where it's like, if a survivor has a substance use disorder, the perpetrator, like that is definitely something that they can not only do with them, whether it's the substances or, supply them with it. And then, if the victim is going to cooperate with the system, then that's just more ammo the suspect can use to be like, oh, well, she's a drug addict, or, she's crazy, she takes all these meds, or, she, so they can use that not only to manipulate the person, but also to manipulate the environment and the system as well and play on those. And so, unless you can get expert, subject matter experts into trials, if these cases ever go to trial, that's something you really have to help convince a jury, to emphasize on of like, this is a person with a disability and these are how perpetrators are taking advantage of people with disabilities. And so taking that into consideration versus like, a jury who doesn't have any of that education is just sitting there wondering why someone that was strangled would stay with that partner or wouldn't try to run or flee or things like that. And so I think so prior history in terms of like childhood victimizations and things like that, that creates, and I think like that fills into the provocation aspect of it, is because like people who have childhood victimizations, particularly like sexual abuse as a child, or grew up in, well, basically have higher ACE scores, so the adverse childhood experiences, essentially what that does is that it conditions our body to be hyper reactive to stress responses. And so like I do a lot of work with the juvenile justice system and helping teachers understand like, you have like the handful of kids that just act out every class and we kick them out and go to put them in ISS, in school suspension and stuff like that. And teachers will say like, I love my job except for the handful of students that do that. But like in my mind, it's like, well, it's a handful of students that probably have things going on that in their personal life that are chaotic, and that's how they've learned to kind of thrive. And so when they go into an environment in school and they have to like sit at a desk and obey rules and listen and things like that, like that's not chaotic, and so it makes them feel anxious, and so that's why they tend to act out. And a lot of that is because it's creating like these hyper reactive stress response systems that if unaddressed, then you have people that become much more irritable, and so they're much more likely to pop off and say things and do things that increase their what we call visibility and puts a target on their back. So going back to that provocation thing, like sometimes like you may have a survivor that has a history of abuse, and there's something that triggers them, and they say or do something, and it threatens the perpetrator's power and control, and then a strangulation ensues and stuff. And it goes back to that evidence collection of like, how do we develop language and statements to address some of these vulnerability factors while being respectful to victims and stuff. Like, I was watching an officer interview a woman that, like, it seemed like she had some developmental disabilities and things like that, and you could just see the officer trying to ask that question in a way that was respectful to get more context to it, and eventually the person was just like, oh yeah, yes, I do have cognitive disabilities and stuff like that, and that was important for the officer. But it is one of those awkward things, because the officer, like, you could tell that they could have, like, they could have benefited from some better language and things like that. But it raises a question: is that something that we should be asking for evidence collection or things like that? Because if I was a prosecutor, I think that would be really powerful in terms of helping a jury understand power and control dynamics and bringing it to light, but at the same time also being victim centered and respectful to the victim and things like that. And so I think that just speaks largely to the volume that, like, we need more people to the table in these cases versus just academics and stuff, because I'm sure advocates and people that work with survivors on a regular basis would have such a either more insight to talk about, or people that work with people with disabilities would have a better insight into the language and things like that. But I definitely think that is definitely an area that we should start to look more into, and starting to identify these vulnerabilities of victims that we don't blame the victim for, but these are things that perpetrators are really targeting and looking and trying to take advantage of.
And I think that's a really sensitive line that you toe really well within the paper, and that we shouldn't shy away from. Kind of understanding what is it about the perpetrator, like you said, kind of understanding perpetrator behavior and trying to interject and influence that positively, but also understanding the victim and the broader context. And I think so much of this speaks to that ideal victim perception of what a victim should look like, or what we expect them to look like. And I think another thing that you speak to in your research is around race and skin tone and ethnicity. Yes. And I think that comes into this as well about, and again, it comes back to, on a very clinical level, data. Are we capturing any of this? What does it mean? But on a practical level, what's the impact that that's having? And you talk about that in terms of kind of visible injury, which is really important.
Yeah, and so that's what thank you for bringing that up, because that was another paper that we looked at, and that just kind of came anecdotally, like, after, like, a few years after we collected the data. The prosecutor had asked me, like, hey, were there any differences in terms of race? Because she was talking with a forensic nurse that was saying that they experienced so a lot of these cases, like, may not have these visible injuries, and for good reason, is because these are full-on assaults and things like that. And so sometimes, anyway, so there may not always be visible injuries. And she was talking to a forensic nurse and saying that, like, actually they see less visible injuries on darker skin tones. And so I ran the analysis. And so to be clear, like, we didn't, it is officers' perception of the race. So whether they just documented it themselves or they asked them what it is, but it's really just the white, Hispanic, or Black is what was on the victim assault form. And so I looked at all the signs and the symptoms, and I ran analysis to see, were there differences to the number of signs and symptoms that officers identified, and did that vary by race? And what we found is it did for the signs, so the visible indicators of disrupted air or blood flow. And so we did see that among white women, they had significantly more injuries documented in their cases. And so what that showed us was that so women that had darker skin tones, officers identified significantly fewer visible injuries. So when I ran the analyses with symptoms, though, so these are subjective things that the victim is telling the officer, like, in terms of, like, my chest hurts, or my neck is sore, things that the officer can't necessarily see. No significant differences based off race. So what that shows us is that skin tone likely is playing a role in this. And in that paper, I was able to read some of the other, and it was also cooperated in the sexual assault research with SANE nurses. And so they've done studies of women who have had consensual and non-consensual sex And they found the same thing. So one study was women that have had consensual sex, and they did a forensic exam, and then others were women that had not consensual sex, did a forensic exam. In both those studies, they found the darker the skin tone, the less likely they're able to see the visible injury. And that is because in skin tone, the darker the skin tone, the more melanin that they have. There was one article that they interviewed an advocate, and she said it best, is that injuries look more dramatic on white women. And there's much more contrast because there's lower melanin in the skin. And so that was really important, or that was really interesting to look at, because that kind of has an implication for the importance of getting medical professionals involved in these cases, and investing in some of these technologies that are coming out, like high-res cameras, but also the UV ray cameras that can actually help increase the contrast in subcutaneous injuries, which are like the bruising and scratches and things like that in darker skin tones. And so some communities are great in that they have, like, anytime that the victim, there's allegations of choking or strangulation, EMS comes out, the victims do not have to pay for it. They don't have to pay for the transportation. And then if they do go to the hospital, they are seen by a sane nurse, and they do a strangulation supplement and all that as well. And so I think that I wish that was much more prevalent. I don't really understand how city governments work. And, like, I know, especially in the US, like ambulances and different things like that, like there's a huge crisis, especially like in rural areas, and in my mind, I'm like, I just don't understand, like, if there's a car wreck with injuries, like the EMS responds to that, why aren't they automatically responding to these strangulation cases and stuff like that, even if the victim doesn't? Because that was the other thing that I saw on scene is victims, like, everyone assumes, like, when the ambulance shows up, like, there's an $8,000 bill that you're going to have to pay for. So that's one more stressor that they have to think about. And so I wish first responders did a lot better at communicating, like, the limitations of that. Like, here in Colorado, it kind of sucks because the victim would have to pay for the ambulance ride, I'm fairly certain, and then they bank on victim compensation to cover that cost, kind of thing. But victim compensation requires cooperation with the system, and I personally feel victim compensation is more of an exclusatory approach, being like, how do we look at the things that would preclude this person from getting victim compensation versus actually helping. And so but, like, it's that just to me is like, so getting medical personnel involved. And then also for the open-ended statement paper, like, I focus much on this concept of forfeiture by wrongdoing. That essentially means that, like, defendants who are charged in criminal cases, they waive their Sixth Amendment right to confront the witness if they are responsible for intimidating that witness or ensuring that they don't come to testify in trial. And so the supplement, I thought, was really good information because it was really getting into kind of the dynamics of the relationship to show that, like, yeah, this victim could be absolutely terrified, especially after the strangulation. So it makes sense in part that they don't want to cooperate because of this perpetrator's behaviors. And if they are arrested and they're trying to manipulate them with the jailhouse phone calls, get them to drop the protection order, all that stuff like that, that is great evidence for prosecutors to use to file that forfeiture by wrongdoing. The other aspect of this is a lot of those open-ended statements that are really golden that can help jurors understand kind of the dynamics of the assault are not admissible unless victims testify. Where those statements are admissible is if they are disclosed to medical personnel as part of their check. And so that's another reason why I wish, we had better policies to get medical personnel on scene or to get victims to medical personnel so that they can ask these questions, that then they are medical experts. They can come in and testify to the things that the victim said and stuff. And so, but I understand that is probably a lot easier said than done. But to me, it just, in terms of, when you're working with survivors that may have darker skin tones, like, it should be going through your head, like, we should get some ultraviolet light source on this to see if we can identify any of those injuries, but also convey, like, just because you might not have injuries on scene, those injuries might show up a few days later, or it could be internal injuries, and encouraging them to disclose what happened to them to a medical professional moving forward if they don't want to get on scene. But that tends to be what I see a lot in a lot of these studies, is that very few of the survivors are willing to get medical help or go seek medical help. And I think a lot of that is because the United States is insane about health insurance and stuff like that. And so you have to be rich to get it. And it's super frustrating in that sense.
And it's so interesting to hear about kind of these like cross-continental comparisons, and although we don't have the same with regard to payment for treatment, we do have disparities with regard to sexual violence or sexual offences, forensic medical examinations not being a parallel offer for domestic abuse, where somebody hasn't been subjected to sexual assault or rape. So somebody's just, again in air quotes, been strangled as a part of a domestic assault. They don't have an equivalent forensic examination option here. So they can go to A&E, but what kind of setting is that for somebody who's just been strangled as part of domestic abuse? But if you have been strangled as part of sexual violence, which could also be part of a broader domestic abuse relationship, you go to a sexual assault referral centre, or you can go to a sexual assault referral centre, have that forensic medical. And our medical director at IFAS talks a lot about this, and actually on the skin tone point in particular has implemented pro formas within sexual assault referral centres as well to kind of capture all that information, advocating for the use of the Fitzpatrick scale for skin tone, which is like a 1 to 6 rating, so less subjective than what you were saying about perceived ethnicity. But anything that we can capture that helps reduce that discrepancy in support and care and response that victims and survivors can receive, the better. And it's just really interesting to hear about there's similar impacts with regard to victim care, but for different reasons, kind of in the US and the UK.
That's fascinating. I never even thought about that connection of how, we have legislation and funding to pay for, sexual assault kits, but if someone wanted to go and do a forensic exam because they were strangled, like, is that also covered, kind of thing? And I guess it would be under like victim compensation or something like that. But like, but that's also interesting too, in terms of like the available medical facilities. Like, if it is like, I would imagine like if it is a facility and there are SANE nurses there, that they are also trained in, strangulation and things like that. But if it's just like a family health clinic or things like that, like they may not know what to look for or how to do that, and whether or not making that connection as well, kind of thing. So it's just, that's fascinating in that sense. And so, I mean, like my wish for the future would be a better understanding of how communities can coordinate that. Like, I would love to like write grants just to like, money to pay for ambulance rides or something like that, to at least like just connect. And I also saw something, I think it was the Strangulation Training Institute, Prevention Institute here in the United States, just partnered with Uber or Lyft to get survivors to appointments and different things like that. And I just thought that was a great idea, that I would like to see if we can like I said, just reduce the barriers to survivors getting the help that they need, and regardless of whether they're going to participate in the criminal justice system, because if they were strangled, especially to the point of unconsciousness, like they are at a very high risk for future medical health issues, and so they may not want to cooperate with the system, but at least doing our part to get them connected to medical professionals, kind of moving forward, especially if that that assault has debilitating injuries. We had one survivor that she was strangled unconscious multiple times by her partner, and she was an accountant. And she went to work one day and she didn't understand anything that they were talking about. So all of her years of training and experience were out the window because some asshole, wasn't okay with being told no, kind of thing. And that's what's just really frustrating about these cases, is that like they create such burdens for survivors, all because of the entitlement and selfishness of an individual who can't cope with their insecurities. But then again, what are we doing to, early on with social emotional learning in elementary school and things like that? I used to do bi-center intervention and healthy relationship education. And I always thought it was kind of corny when I first heard about it. But now I'm like, no, this is really important, because like no one ever teaches you how to deal with jealousy. No one teaches you really how to deal with conflict unless it's like your parents and things like that. But like, giving people different resources for how to deal with these things that are driving a lot of the drama in relationships, such as like our own insecurities, jealousy, conflict, things like that. So preventing that early on, but then also having resources for the people that are perpetrating these crimes, and actually having those resources that address some of the underlying issues, versus just a checkbox of like, well, they did 52 weeks of this program, so they're not going to be violent anymore.
It's not addressing those mediating factors in between, kind of cause and effect. You don't just go from kind of maybe normalization of violence to then doing it yourself. What changes in the psyche of those people that they kind of change their attitudes towards women, towards power and control, as you've spoken to.
And lastly, just the work that y'all are doing with strangulation and sex too, like that's something as a college professor that like I want to start bringing up a lot more in my classes, to be like, watch whatever porn you want to watch as long as it's, you know, legal and stuff like that. But like the choking and the strangulation, like that's not the vibe unless you're into it. Like we're not here to kink shame, but like understand that like I think someone said it in the last meeting, like there's really no safe way to strangle someone, kind of thing. Like even talk to MMA people and stuff. And so like I don't love that is becoming kind of more common among these college students and stuff like that. And so you know, and it's being done in contexts where the victims are like, oh, this is just what they wanted, or you know, it's like it was kind of normal kind of thing. And so it's just like I don't feel like we should be normalizing that, like not obviously not to kink shame and stuff like that, but at the same time understanding like just providing more information out there and the risk of it, so that victims can actually make informed consent if that ever happens, you know, during sex or whatever.
Absolutely. This is all about information, isn't it? And supporting people to make choices if they can. And that goes back to practitioners as well, in how they respond to these cases, victim survivors in domestic abuse settings, in terms of what their options might be after something has happened and how to do that and engage with that safely. And yeah, across strangulation in different contexts, it's about information, which you know, it's quite corny, but it brings us back to the importance of research and kind of how important it is to capture all of this and be able to communicate it to the people that need to hear it ultimately.
Absolutely.
Yeah. Amazing. Do you have anything else you want to add?
No, I think we covered a lot. This is, I mean, I could talk for hours. I love all this, but yeah, we covered a lot of what I wanted to talk about. So this is great.
Thank you for listening to this episode. You can go onto our website ifas.org.uk to access further reports, research and podcasts on strangulation.